I want to make a comment as well about this. Because the story, as you may have noticed, is not over, because whenever you have two trials, you got to look for the tiebreaker. And I think that's very important for us to know. There is a studies happening, evolving, reduce HF, again, with a similar approaches to the mitral regurgitation, but with a slightly different population. So that will come out as well. That will be also complementary. This is run by the EuroCHF Society. PI is a past president and I think a mogul of heart failure in Europe, Dr. Anker. And, we're going to hear from that as well in a year or so. So it's not exactly out and no studies done and all that.
I actually want to make a comment about
Now tell me about that.
I do. I actually know first of all, what was it? That's called not research. Right, that's right. So they took how many years? 12 years to enroll, because they started like many years ago before us, and then they stopped and then restarted again. But I'll tell you one thing: you can't discard the present data. So for this subgroup of population which we chose, whatever that way we chose them, this is a dramatic difference. So if you get a patient with ejection fraction of 30% with severe functional MR who's in guideline-directed medical treatment, do you think you're not going to give him MitraClip?
Well, no, of course, but as we all know, that a lot of people are generalizing this data to anyone with MR.
No,
and that's why, no, you're not, but you're not. But, I can tell you, if you take a poll, who even realizes what the effective orifice area means and what the values mean and all that? Let's be a little realistic. So before we go to a bigger populations and wider populations, you need to have all these additional studies. That's all we're saying. If you have a carbon copy of the inclusion criteria of the MitraClip trial, absolutely, go ahead. There's no question about that.
Well, what will happen is that I think echo people and heart failure people have to become the equation.
Yeah.
To make sure that the appropriate treatment is taken.
Yeah.
Okay.
I think we're saying the same thing. Very
Wonderful. So let's go to this, and then we're going live because we have too much.
good. So I'm giving my talk before the live case. Okay, great.
Quick.
Great. And just exactly, I think this question was asked during the live case. So that's great to actually have a talk about it and address the aspect of anticoagulation around TAVI a little bit systematically. I think that will complete the TAVI lectures, and we're going to then focus more in the mitral program. All right, we're running quite a few studies about that at Mount Sinai, and this is my related COI statement. And first of all, let's acknowledge that the TAVI population is rich in events, including cerebrovascular potential events, peri-procedural, inclusive of AFib, including the chronic AFib and the new onset AFib, as well as a population that is growing. And if you look into all TAVI trial candidates and enrollees, the CHA2DS2-VASc score on all of those is very high, regardless of AFib. So there's essentially a rich population for such events. And on the pathologic basis, there is a vast difference between the normal leaflet and the stenotic leaflet of the aortic valve. And the difference is that you can see there's a lot more brown stuff when the leaflet becomes stenotic on the right side, and the brown stuff is tissue factor. Once you expose that to the circulation by disrupting the valve, it is understandable very easily that you will have some thrombotic tendency in that vicinity. The prosthetic valve thrombosis or tendency to thrombosis obviously is not a singular event that has to do with tissue factor, bam, you got it, and everything thrombosed. It doesn't work like that. It's a multifactorial, including an interaction between surface factors, hemodynamic factors, and hemostatic factors, pretty much as in thrombosis in any other vascular bed. You just have to adapt them the right way around the aortic valve. We heard and we saw many things about that. Just saw the photo of this of some events around the capability, just to demonstrate the capability of the dynamic CT angiography to pick up the new entity that is called hypoattenuated leaflet, leaflets that don't move very well and all that. The classic techniques, they don't show it very well, and it's actually very difficult also to image the CTA the right way, but everybody's learning because everybody's motivated to picking up those events. impact of anticoagulation of bioprosthetic valve hemodynamics and clinical outcomes is diverse and is three-faceted. On the left side, you can see the hemodynamics. The event, very soft, difficult to pick up with the gradient changes. On the right side, the clinical outcomes. Not so dramatic strokes, etc., that everybody was fearing. There's some signal for TIAs for the most part. Bleeding is always a consideration applicable to every single patient that may take these techniques. So what you can offer them is at the top, and what you potentially risking is at the bottom. And unless we realize very well what the risk ratio is, the risk-benefit ratio is for this patient, it's very difficult to just say, you know, what do you really do right now? And, you know, I'll come up with a great answer that everybody thinks is right until later on we find out there's more strokes or more bleedings no matter what my answer is. So the answer is we just have to look for the answer. And I'm very disappointed that this field, which is actually a lot of bioprosthetic valves have been used for I don't know how many years, many years, in the surgical field, of course, and there is no data. So the repetition of that everything is great just because we're not looking into anything and we don't have any systematic trial is actually just kind of sort of, you know, a little bit of nonsense. If we don't know what's going on, that's why we think everything is good. So naturally, the guidelines are consensus-driven, based on retrospective data and things like that, based on the mechanisms of disease and all that. True randomized prospective trials really don't exist, neither in neither kind of valve. All right, and whoever comes up and says everything is rosy in the surgical aortic valve prosthesis, bioprosthesis, is just simply saying that, you know, nobody looked at it and we think it's good. Interestingly, and starting from Professor Usia over here, who is with us today, performed the first randomized study, very small, pilot study obviously, of dual antiplatelet therapy versus simple aspirin in patients with TAVR. Again, striking right on the fact that, you know what, we're giving DAPT based on coronary data. Is there really any benefit in TAVR? And nothing really terrible happened to his patients. In fact, and this is a mix of a few studies that all of them had like about 200 patients altogether. Dr. Usia's was the first study in 2011, and all of them kind of the same flavor. No, a wash in MACE, no difference, but significant risks regarding bleeding regarding these patients. The largest study of those completed last year was the Aortic trial. It was about 200 patients, a little bit bigger, and again the same design, aspirin versus DAPT. And you can see that regardless of the event, the solid line was worse than the dotted line. And the solid line was a DAPT. The simple aspirin is a dotted line with less bleeding and numerically less of everything, however you measure it, even in MACE. Warfarin in a combination, again, therapy including warfarin, retrospective data, things not so great. Combination therapy worse than the single therapy. Again, retrospective, you don't know why people are in that, but things certainly don't look something I'm proud of. Well, everybody has 20 and 25% events here. This is not so good to kind of navigate a little bit blind in this population. Similar flavor from the France-TAVI registry just a few months ago in patients with anticoagulation after TAVI. You know, that's not exactly a great thing to say, you know what, we're going to anticoagulate everybody just because we feel good. If you look here, anticoagulation had worse events overall. So it's not like, okay, we saw something on the CT, let's give Coumadin to everybody. That doesn't exactly seem to be very well thought of at this point. Interestingly, this paper came up earlier this year, which is essentially a survey, a meta-analysis of 45 TAVI centers that showed very clearly that the actual practice is all over the place in a very, very clear way. Only 12% of the people said they're following guidelines, and everybody else said they're doing whatever pretty much they feel. 40% they do their own thing, and another 40% said we do whatever the hospital does. So you can see there's a very hodgepodge both in the selection of the therapy as well as in the duration of the therapy that you see on the bottom right. They give it for a month, maybe they give for 3 months, others give for 6 months, a minority give for a year. clearly a hodgepodge situation. There are many studies undergoing to address in a regimented way several of these issues. And in general, the approach is to investigate patients with versus without oral anticoagulation indication. And you can see on the left side the column of patients pretty much in, without a straight need for OAC, and on the right side, patients with indication to OAC. I'll see you some of this design. The Galileo trial is a patient with normal sinus rhythm, investigating the low dose rivaroxaban of 10 milligram in combination with aspirin versus DAPT. We're going to have results in ESC 2019. The DSMB found some safety signals, and this follow-up ended this fall. So we'll have the full set of results in 2019, and we know more about that. Obviously, this is a low dose, not fully anticoagulation, but still things didn't work very well in this population. This will be presented together with the CTA sub-study as well as a serial MR brain sub-studies in order to better understand the mechanisms of disease. Atlantis trial, primarily in France, as well as expanding elsewhere in Europe. 1,500 patients, all inclusive. Here they go full dose anticoagulation with apixaban versus two kinds of control groups according to the use of Coumadin or DAPT. ENVISAGE, which we have in the United States, we have about 600 patients right now, 580. We aim to have by next year this time the study completed. This is all AFib population in TAVR, a simple randomization, warfarin versus edoxaban, with obviously adjustment for renal failure as needed. Finally, we try to proceed with a CLOID trial with the NHLBI, 4,000 patients, just to follow in the original pilot study of Dr. Ucia, no clopidogrel versus clopidogrel in TAVI, just to show if there's any benefit or is really only risk of bleeding in these patients, even with clopidogrel. Right now, the best thing to do is to enroll in the studies. Any non-vitamin K oral anticoagulant is off-label for this population. Not many clinical doctors know about it, and certainly not many families know about it. They think they know, and obviously everybody likes the ease, but we have to be careful about that. Until then, we just follow the recommendations we discussed during the live case. We just be cautious, individualize, know that the guidelines are not evidence-based but consensus-based, understand the off-label issues with the new agents, and participate in the trials. Thank you for your attention here.